My name is Ned Brooks, and it is my distinct pleasure to spend a few minutes today with Dr. Robert Montgomery, the head of the NYU Langone Transplant Institute. Dr. Montgomery is an extraordinary individual in more ways than we have time to discuss today. Our goal is to have Dr. Montgomery provide insight into the state of kidney transplant in the age of coronavirus. A quick recap of some highlights in his life. Dr. Montgomery graduated University of Rochester Medical School in 1987 and joined the Johns Hopkins team where he trained as a surgeon. He participated in the first laparoscopic kidney transplant in 1996, and he was the lead surgeon in the first paired exchanges and the first 10-way kidney chain. In 2016, Dr. Montgomery was recruited to head the new transplant center at NYU Langone, which, in addition to kidney transplant, is now active in liver, lung, and facial transplantation. Dr. Montgomery knows better than most both sides of transplant. In 2018, a congenital heart condition reached a point where Dr. Montgomery was forced to seek a heart transplant. He accepted a heart that carried hepatitis C. The transplant was a success, the hep C was cured, and we're pleased to be talking now with Dr. Montgomery. Doctor, thank you for taking the time to talk with us today.
Thank you, Ned. Thanks for having me.
So let's start by asking you to give us the state of play in transplant at NYU and Langone. About 40% of the transplant centers affiliated with the National Kidney Registry are closed. You are open for business. Why is that, and how are you managing?
Well, so I would say that we're open for business for a very select group of recipients who, in our opinion, the balance of risk, so sort of the equipoise of the risk of acquiring COVID-19 versus delaying, their transplant would suggest that they would be better off undergoing a transplant at this point. And that's a very small group of patients that have remained active on our list during this time. We are now starting to liberalize that more. And again, we've gone through our list and done this sort of calculus, this risk-benefit decision for each patient on the list. And we have now reactivated a fairly large portion of our lists in all of the organs. So we feel now that we're over, this peak and on a better trajectory as far as the number of cases in New York that we're able to do this at this point.
Very good, thank you. And I understand that your efforts on kidney transplants focus on living donation right now. Why are you not doing deceased kidney transplants at this time? And what needs to happen for you to restart that effort?
Yeah, so we did have a couple of living donor kidney patients who were really, very close to needing to go on dialysis. And, I think one of the things that has come out during the last 2 months is that patients who are in dialysis units seem to be at a greater risk for acquiring COVID-19. And so, we felt that, again, that this balance of risk favored us going ahead and doing their transplants now. We feel that the hospital now is a safe environment, and we put a lot of different, we've exercised great caution in terms of the policies and procedures that we've implemented. So we feel that the hospital is very safe now. We are starting our deceased donor transplantation. We've activated a lot of our kidney, liver, lung, heart, and pancreas lists. And so I think, in the next week or so, we'll see some more deceased donor transplants being done.
Well, that's good to hear, and I know that the entire industry is anxious to get the transplants back up to speed again. If you were to compare the COVID-19 pandemic and its impact on organ transplantation to another healthcare challenge in the past, what would it be and how can we learn from it?
Yeah, so boy, I've been through two, you know, plagues basically in my career, and the first was HIV in the 1980s, and I lived through that. I was a surgical resident during that time. And those were really scary days, and they were particularly scary, I think, for anyone who needed blood transfusions or transplants. Before we could routinely diagnose early HIV, there was a pretty large window period where the disease could be transmitted and not um, identified in a donor. So that those were very challenging times, but I think this is in a way even more challenging. Um, we know now after the last 2 months in the hotspot that is New York City, that our transplant patients have been disproportionately affected by COVID, and they seem to have um, uh, been infected at a higher rate than the general population, and they haven't done as well as the general population in terms of the outcomes, and seem to be somewhere between 5 and 10 times more likely to succumb to the disease. So it's very concerning, and it really has forced us to have this pause period where only the most life saving procedures have been done, where that balance again, that balance of risk versus benefit has favored doing a transplant, despite the fact that we know that the patients, when they get COVID-19, have a poor prognosis.
Wow, those numbers are startling.
Yeah.
Um, with the severe shortage of organs available for transplant, an obvious goal would be to use all available organs while observing maximum safety protocols and ensuring long-term successful allograft outcomes. What could the transplant industry be doing better than it is now? And how would you recommend implementing those changes?
Well, I mean, I think that question is layered and it's a bit complicated because of COVID-19. I think right now we're in a new learning phase, with a very steep curve, and we're trying to figure out what is going to be safe and what's not safe. And in particular, we're really focusing on uh, donor safety, both living donor but also deceased donor, because as people who are dying right now, there's oftentimes a question of whether COVID could be um, part of the cause of their death. We know that this disease has many different faces, and it can be very confusing sometimes to make the diagnosis. So we're really assessing the donors, on an individual basis very carefully with our infectious disease colleagues to try to be sure that the risk is extremely low that the donor could have acquired COVID-19 and could pass that on to the recipient. So that's where a lot of our focus right now is, on safety. I think your question in general probably applies more towards, how can we improve things for patients over the long term? And that's something that I've been really focused on, in particular since I've had my transplant, because my journey has taught me a lot about where the holes are in the system. And I think in particular, the way our healthcare system is set up, we're very focused on that first year after the transplant, but after that, sometimes I think patients start to struggle, and it's not always, something that the transplant community recognizes. I think in particular, one of the things that I've really focused on is the challenges that people have after a transplant and getting back to work, and really being returned to, that level of engagement in society that we all hope for, after a transplant. And, I had my own struggles with that, getting back into the operating room and doing what I do. So and I think because of that, I every time I see one of my patients or talk to any patients, I ask them about, how is it going? What are you doing? Are you back to work? Are you engaged in the things that you want to be engaged in? Are you able to do those things, as you had hoped after the transplant? And so I'm really trying to focus a lot on trying to help to equip patients with the tools that they need to do better over the long haul. Because what I found is, from looking at the data, is that only about 20% of kidney transplant patients go back to work after the transplant. And I think there are many reasons for that, but I think we could do better than that. So I brought together a lot of people at NYU to try to start some pilot studies to see if we can intervene early and help people to get more fully engaged after their transplant.
I was not aware of that 20% figure. That's alarming and concerning. Is that, do you think, because of a lack of follow-up on the part of the interested parties in medication levels or psychological counseling, or what do you think makes that up?
I think it's all those things. And one of the things that I've certainly learned is that, when you become a patient, a transplant patient, it's almost a full-time job in and of itself, just keeping your visits, organizing your medications and your follow-up. It's very taxing. It takes a lot of time and effort. I think the nature of kidney disease in particular is such that there's this long period of time when you're, in some way incapacitated by end-stage kidney disease, whether it's, when you're on dialysis, or even in those lucky folks who are able to get transplanted before they go on dialysis, they may still, be out of work. They don't have the energy that they had prior to their kidneys failing. And so I think there's this decline that occurs both physically and globally. And then I think also the way that we've set up, insurance and Medicare and a lot of these things, that when patients get their transplant and they're on disability and on Medicare, it's very frightening to, sort of take the risk of releasing those benefits and getting back into the workforce, because there are bumps in the road for almost all transplant patients after the transplant. And when they're in the midst of those bumps, they wonder, like, what would I do, if I were working now and, couldn't come to the office for 2 weeks, would I get terminated? And then, what about healthcare? And so I think there's a lot of things that we can do. And then I think also a lot of kidney transplant patients don't get enough rehab, physical rehab either, so that they maybe don't get all their strength back the way they were before they developed kidney disease, because that's such a slow, insidious process. So I think we need to just really direct a lot of resources on the patients, job counseling, psychological support, help with insurance and just really understanding, how to balance these things, taking care of yourself and also getting back to work or whatever, you want to be engaged in. It's not just sort of that, that box of, a conventional job, but, really being able to do the things that you want to do and that you had hoped you'd be able to do after the transplant.
Thank you. Um, you're in a unique position as both a transplant surgeon and as a heart transplant recipient. We communicate with a large number of kidney recipients, and I know that they are extremely focused on maintaining the proper protocols in quarantine. Being immunosuppressed, they feel vulnerable and frankly, they're scared. What advice do you have for transplant recipients, both during this quarantine period and as we move to opening up the country for business and social interactions?
Yeah. So, as I mentioned earlier, what we're beginning to learn is that, in particular, kidney transplant recipients seem to be at considerable risk for having more severe disease from COVID-19. We don't really fully understand, what the contributions, of immunosuppression versus other conditions that go along with kidney disease, like diabetes and high blood pressure and heart disease, how much each of those things contributes to that poor prognosis. But it's pretty clear now, from a number of sites during the last couple of months that this is the case. This is true. And so, until we have a vaccine, I think that transplant patients are going to have to be really careful. And, I think there's pretty good advice out there from the various state Department of Health groups and from the CDC and, from the federal officials about what that looks like in terms of what you need to do to stay safe during these times. But I think that life for transplant patients will probably not get back to something that resembles something normal until there's either a better treatment or a vaccine. So I would recommend a lot of caution. I do that, in a judicious way to not try to cause fear or excess concern. It's really just with from what I have seen and experienced these last couple months, just a sense that we have to be really careful, and that the idea that things are kind of moving back towards a normality for most people, I think should not entice the transplant community to think that it's okay to not wear masks, to take risks, to not social distance and things like that. That's going to be with us, and it's going to be with us for a while. And I think as some of these things are relaxed, we have to be more vigilant. And in the fall, when we move into the regular flu season, we have to be very vigilant at that time too.
I can only imagine what your personal life must be like as a heart transplant recipient in a theater where there is nothing but bacteria and microbes around you all the time, and how you handle that with equanimity. It's quite remarkable. Okay. Kidney donors are generally in better health than the average population, but we only have one kidney, and we know that this virus can be tough on kidneys. Are living kidney donors at greater risk with this virus than the general population? And do you see this issue as a potential deterrent to living kidney donation going forward?
I don't. I mean, I think, we do see in the patients who are critically ill from COVID-19 disease, um, somewhere between 20 and 30% of them develop what we call acute kidney injury. Now, most people, as long as, they recover, their kidneys recover as well.
Uh,
Um, and I don't think that it would be that different if they had one or two kidneys, quite honestly. So I mean, hopefully we're going to get this disease under control, and that large portions of the population are not going to end up getting infected, and that we'll have a vaccine or a better treatment before um, we approach anything like herd immunity on its own. And so my hope is that you know we won't need to be worried about that. But I do feel though that having one kidney versus two for this disease probably doesn't make that big a difference in terms of the impact that the disease has on the kidney. So I think that if you develop acute kidney injury, you would be just as likely to develop that if you had donated a kidney versus if you still had both of your kidneys.
Thank you for that. Given your position as both a transplant surgeon and organ recipient, do you find that your patients have greater faith in your expertise, having been on both sides of the operating table?
Yeah, so that's an interesting question. So I think, I certainly do have patients who come to me who, are attracted to that aspect of who I am, that I have perhaps a better understanding. Well, I do have a better understanding of what they're going through. And I've had quite a few physicians too with kidney disease, and even some surgeons who have come to me in particular because they've known that I've gone through my own struggle in terms of the effects of the immunosuppression that can be relevant to surgeons and physicians. And so, yeah, I think that is something that it gives you a different dimension, certainly, to your bedside manner, if you will, with the way in which you can connect with your patients. I don't recommend it to all my colleagues, but it certainly has opened my eyes to many things.
Well, and going back to your answer to my earlier question, about how you get yourself back in the saddle after going through something like that, you certainly walk that walk. Dr. Montgomery, you've been very generous with your time. Is there anything you'd like to add before we wrap this up?
Well, I think again, I'm using certainly, an excess of caution in my recommendations, and I don't want that to engender any sort of fear, because I think fear is not a healthy thing. I think transplant patients, should be confident about life, and should really feel that they're in a position to fully enjoy life. However, we are in the midst of this unprecedented situation that we're dealing with, and so given those circumstances and what we know so far, I just ask my fellow patients who are immunosuppressed to just be really careful and just follow the recommendations that are out there that we all know about. And we're all going to have to lay a little bit low during this year, and there's great hope that will change going into 2021. So I just want to close by just saying that, just take care of yourself and be smart, and enjoy the things that we're getting out of this isolation too, and this quarantine. There are a lot of there's a lot of silver in that lining, that I've found too, and enjoy your families, and maybe a little more of a quiet life than we're all used to.
And with that, Dr. Montgomery, thank you so much for your time. Appreciate it.
Okay, thank you.